It is 2 o'clock. It is the time to get started, and so I'll do a quick introduction. Thank you for everyone who's joining us, and I'm sure a few others will join us as we go. We have the opportunity to hear about migraines today. Dr. Umar Najib serves as assistant professor here at WVU in the neurology and is the program director of the Headache Medicine Fellowship. So pretty busy. He completed his neurology training at WVU. His subspecialty training includes a clinical fellowship in headache medicine at the Brigham and Women's Hospital at Harvard University. He is a research fellow in non-invasive brain modulation at the Berenson Allen Center at Harvard University at that time. Dr. Najib has authored or co-authored several peer-reviewed publications involving neuromodulation, and his current research interests include the use of non-invasive neuromodulation for treatment of neurological disorders, including, but not limited to, migraine and chronic pain here at the Rockefeller Neuroscience Institute at WVU. So with that, I'll just mention some brief housekeeping. If you haven't already, please make sure that your setting is on mute, either through your computer and or phone, whichever way you're connecting with us. We will have some time for questions at the end, and then also, because we're doing this through WebEx, we also have the function, the chat function. Down at the bottom, you should have some menus, and there's a little comment box at the bottom. You can click that, choose whether you want to send it to one person or the group, and we'll make sure that we can address some questions at the end through that as well. Okay, with that, Dr. Najib, I'll turn it over to you.
Thank you so much, Dr. Cottrell. Thank you for the nice introduction. So everyone now knows I'm Umar Najib. I'm going to talk about migraine today, and when Dr. Cottrell had asked me to present at this, there were a few options. I chose this topic because this is something we see the most disability associated with, and we see our patients suffering from migraine to have certain challenges which are unique to the underserved populations, and I'm going to briefly talk about those as well. Okay, so let me figure out. Okay, perfect. So I'm going to talk about the on and off label use of certain medications and devices. I do not have any current financial disclosures. The objective of my talk would be to give you an overview of migraine, discuss briefly the diagnosis of migraine, outline the basic treatment principles in migraine patients, and then talk about the disability associated with migraine, especially in the underserved populations, and finally identify some of the resources that are available locally at our headache center and then nationally online as well. Okay. So my PowerPoint just crashed. Let me see what's going on. Okay. Can everyone hear me? Are you all still able to hear me?
Yes.
Okay. I'm quickly going to restart the software. I apologize. I don't know. Okay. Well, hopefully it's not going to crash again. So let's start with the lifetime prevalence of some common headache disorders. Now, as you can see from these numbers, tension type headaches, or as some patients like to call it, regular headaches, they're nearly universal. A migraine is not universal, but it's still very common. It's present in up to 20% of the population, and that's about 37 million patients with migraine. It's actually more common than diabetes and asthma combined, and yet it's severe and disabling. Then the next one in the primary headache disorders is cluster headache. Now, you may think that it's rare, just 0.5%, but the prevalence is as common as MS, multiple sclerosis, something you hear about a lot, but you don't hear a lot about cluster headache patients. It's considered one of the most painful disorders known to man. In the secondary group, as shown, sinus disease is also very common. But interestingly, the non-vascular reasons for headaches, which are typically because of tumors, the prevalence is quite small. Now, partly this is due to the fact that tumors are infrequent occurrences, but also partly because, contrary to the popular belief, headache is not a particularly common presentation of tumors. Now, moving on to migraine, which will be the focus of today's talk. So what is migraine? And it's a complex disease. And this is one way of defining migraine. It's a neurobiological disorder which has both genetic and environmental components, which causes a hyper-responsive brain state. And that leads to episodic attacks, which include severe headache, nausea and vomiting, light and sound sensitivity, activity intolerance, among a host of other symptoms. Migraine can be classified into either episodic migraine or chronic migraine. Episodic migraine is patients with migraine who have less than 15 headache days per month. Chronic migraine is defined as patients who have more than 15 or more headache days per month, with at least 8 of them being typical migraine attacks. Let's quickly go over the migraine epidemiology. Now, I mentioned 37 million patients suffering from migraines, about 12 to 13% of the US population. Chronic migraine, the prevalence is about 1 to 2% of adults. So 1 in 4 households has a migraine patient. It's the third most prevalent illness in the world, and the total direct and indirect costs associated with migraine amount to about $36 billion. And that's huge. There are several risk factors for disease progression or for transformation of episodic migraine patient to chronic migraine patient. And some of these risk factors are outlined here. And as you can see, most of these risk factors are the population that we serve in our state. Most of these risk factors are pretty prevalent. So low socioeconomic status, low education, obesity, depression, and then along with that, a high frequency of episodic migraine attacks to begin with, and then overuse of acute medications or ineffective acute treatment are some other risk factors. According to WHO, this is the 6th most disabling illness in the world. The peak prevalence is around the age of 40. The greatest impact is between the ages of 25 to 55. And as you can see by the 2 graphs, it affects females much more than males. So how do you diagnose migraine? The diagnosis is based on pattern recognition. The vast majority of headaches that are seen by a healthcare provider are primary headaches, or those which do not have an underlying cause. But making these diagnoses is not just about excluding things that may be causing headaches. It's about diagnostic criteria as well. And this is the diagnostic criteria for migraine without aura. I'm going to briefly mention here there are two main subtypes of migraine: migraine without aura and migraine with aura. About 2/3 of patients have migraine without aura, and about 1/3 of patients have migraine with aura, which further has several subtypes. Now, as you can see by this diagnostic criteria, this is the International Headache Society diagnostic criteria for migraine, that there are several unique disease characteristics that are needed to make the diagnosis, and some of which are unilateral location, the pulsating nature of the pain, the severity of the pain, aggravation with activity, nausea, vomiting, light and sound sensitivity. So how do we evaluate? So the clinical priority of the first diagnostic evaluation is to identify the warning signs, and they also include an abnormal neurological exam. So it's either in the history or in the physical presentation. And if their warning signs are present, then suspicion of a secondary headache disorder, which means a headache because of an underlying cause, that should be considered. In the absence of the warning signs, the headache disorders is likely a primary headache disorder such as migraine, and diagnostic criteria need to be reviewed. Are those warning signs or red flags? And here are some of those. The typical recommendation is new onset of headache after the age of 50, so in the elderly population. If the headache pattern is unusual, it does not qualify a certain diagnostic criteria. If there's a positional component to the headache, or if there's a worsening with Valsalva maneuvers, and these indicate an underlying trigger or an underlying component with a change in the intracranial pressure. If there's worsening over time, if there's an abnormal exam, or there's no response to treatment. So all these could be considered warning signs, and this would warrant investigations. This would warrant testing. There is no role for EEG in the testing of headache disorders, particularly migraine. And you'll be surprised how often patients go through these tests, go through an EEG during the workup for headache disorders, or during the workup for migraine, which is inappropriate. Neuroimaging is the mainstay of evaluation when a secondary headache disorder is suspected. So, which scan would you order? Now, here are some of the things to consider when we think about ordering a brain scan. CT is good to rule out a bleed. So if there's a history of trauma, a CT scan is useful. If a problem or disease with the bones or sinuses is being considered, then CT scans are helpful. Out of these situations, MRI is the study of choice. So by default, MRI is the study of choice unless you're suspecting bleed or sinus disease. And during workup of headache disorders, an MRI with contrast is much more useful than MRI without contrast. And the reason for that is in order to evaluate for CSF pressure changes and tumors, contrast is needed with the MRI. There are certain other kinds of imaging modalities that can be used. MR angiography, or MRA, is useful when an underlying vascular abnormality is considered, such as carotid dissection, an intracranial aneurysm, intracranial vasculitis, venous vasculitis, and an MRV or MR venogram is helpful when, once again, when CSF pressure changes are being considered. And pregnancy is one situation where an MRV is helpful because to evaluate for cerebral venous sinus thrombosis, since pregnancy is a prothrombotic state. So if I see a patient who does not have any warning signs and who fulfills the criteria for migraine, do I need to order imaging? And the answer is no. American Academy of Neurology came out with this position statement a few years ago that if a patient meets the criteria for migraine and has a normal neurological exam, then imaging is not recommended. Okay. I am so sorry. I think there's some sort of conflict and it just crashed again. Okay. So we'll restart from where we were. So this was a very interesting study done in 2000 by Frischberg. He looked at more than 1,000 patients who fulfilled the criteria for migraine and had a normal neurological exam. And out of those, only 2 patients had abnormalities detected on the imaging. Now, in patients who did have an abnormal neurological exam, they were 3 times more likely to have abnormal neuroimaging. So the take-home message is that if with a normal neurological exam, if someone meets the criteria for migraine, imaging is 99.9% likely to be normal or show a minor abnormality that wouldn't change the management. I wanted to talk a little bit about non-specific white matter lesions. And I bring this up because healthcare providers often end up ordering an MRI on patients who have migraine, and then they see non-specific white matter lesions written in the report, and that's a big concern for patients, and then MS is being considered, and so many other neurological disorders are considered at that point. Migraine patients have non-specific white matter lesions significantly more than normal population. So unless the radiologist tells you that the white matter lesions are in a particular pattern which raise the suspicion for other problems, just having non-specific white matter lesions for someone who fulfills the criteria of migraine is very normal. So I'm quickly going to talk about migraine aura. If you remember, I briefly mentioned that 1/3 of migraine patients have migraine with aura. So what is aura? Aura is any focal neurological event, it's typically visual, sensory, or motor, usually precedes the headache. It's either positive, negative, or a negative phenomena. It typically spreads and is reversible in nature. This is the diagnostic criteria for migraine with a typical aura. And as you can see, the highlighted parts include either reversible visual symptoms, reversible sensory symptoms such as numbness or pins and needle-like sensation, reversible speech symptoms. They gradually develop over at least 5 minutes and then typically last between 5 and 60 minutes. And one of the symptoms needs to be unilateral. So what does all this mean? Well, one thing, when the spreading nature means that if there are sensory symptoms, the patient would typically experience them either in the hand first and then gradually would spread over the arm, the face, and so on. Visual symptoms typically would either start in the center, move to the periphery of the vision, or start in the periphery, move to the center of the vision. And similarly, there's gradual progression and they're completely reversible. The most familiar pattern is visual aura. The visual aura is typically described as a flash bulb sensation or as a set of shimmering, bright zigzag lines in the field of vision. It's important to note here that simply having blurred vision or foggy vision is not visual aura. It has to be, the visual aura is either a positive symptom or loss of vision, a central blind spot, and so on. How do we manage migraine then? Well, the two types of therapies for migraine patients. There is abortive treatment, as the name suggests, something to use to stop an attack, to abort an attack. And then there's preventive treatment. These are the treatments or the medications that the patients use on an ongoing basis to prevent migraine attacks from occurring. Everyone needs abortive treatment, meaning all migraine patients need abortive treatment. Only a subset of migraine patients require preventive treatment. The typical recommendations are that if the headache frequency is about 1 per week or more than that, then preventive treatment should be considered. The most commonly used preventive treatments are daily oral medications, and I'm going to briefly talk about them in a few minutes. Botulinum toxin, until very recently, was the only FDA-approved preventive treatment for the chronic migraine patients. And then there are several new medications that you might have heard about recently in the news, some of which have the FDA and some of them are in the pipeline. This is a new class of medications called the CGRP monoclonal antibodies, calcitonin gene receptor peptide. So I'm going to briefly touch on them in a few minutes. So let's start with the abortive therapy. So as I mentioned, abortive treatment is, these are the medications a patient would take when an attack starts, to stop an attack. There are several non-specific options listed here, but migraine-specific abortive therapies are mainly ergot derivatives and triptans. Triptans being the mainstay of abortive therapy, simply because ergots in oral form or nasal form or even injectable form have a very, very low bioavailability. The only way to effectively use ergots is through IV infusions, and for those, patients need to be admitted. So triptans are the mainstay of migraine treatment. There are 7 triptans in total, and 6 of them are now generic. One is still not generic, but the other ones are generic now. 2 of them are available as oral tablets. There are 2 available as nasal sprays. There's 1 available as a sub-Q injection. Sumatriptan, which is the oldest of the triptans, it's in some countries it's already available without prescriptions, over the counter, and UK is one of them. These are the common triptan side effects: tingling, some warmth, flushing, chest discomfort, dizziness. Now I mention this because this is important. Patients who experience these are not having an allergic reaction to triptans. Over several years of my practice as a headache specialist, I can probably count on one hand the patients who had true allergy to triptan. And you'll be surprised how often I see patients in the headache center where the triptan is listed as an allergy, and we do another trial of another triptan and they do just fine. All these are common triptan side effects. This is not an allergic reaction. There are certain contraindications to triptan use, and these are primarily cardiovascular in nature. So any patient with coronary artery disease, poorly controlled hypertension, or risk factors, multiple risk factors for coronary artery disease, we have to be a little careful in those patients, because triptans are vasoconstrictors. So someone who already has constricted or blocked coronary vessels, having vasoconstriction as a side effect of triptan use can complicate things. This is another important concept to understand. There have been multiple studies done which have shown that triptan non-response is not consistent. Most of the times, someone who's considered a non-responder to triptan is either using the medication too late, using a lower than adequate dose of the medication, is using an inappropriate formulation of the medication, and so on. There have been 5 studies which showed that switching from one triptan that was ineffective to a second one can result in a positive response. And then there have been studies done which showed that increasing the dose can result in a response, can switch a non-responder to a good responder by giving an appropriate dose. Teft-Hansen showed this with naratriptan, known as Emerge. You can see going higher on the dose increased the response rate up to 88%, and this response rate is pain freedom at 2 hours time point, which is huge. Peter Goldsby showed that using elmotriptan early on, when the pain severity is still mild, results in a much better response compared to when it was used later on in the duration of the migraine attack. And this is based on the pathophysiology of migraine and the site of action of triptans. The triptans work on the peripheral receptors where the migraine process starts. And if there's a delay of 1 to 2 hours, the process has sort of moved on to involve deeper areas of the brain where triptans are not able to penetrate, which is inside the blood-brain barrier. Another important concept to understand in these patients is that barbiturates and opioids have absolutely no role in the treatment of migraine. Now, opioids is done showing that opioid use not only increases the risk of ER visits, it also decreases response to treatment with non-opioid agents later on, but can also cause opioid-induced hyperalgesia with repeated use. In headache medicine, in migraine treatment, there is absolutely no role for opioids. And I also mentioned barbiturates. These are commonly used medications, Furoset, Furanol, which have butalbital in them, which is a barbiturate. They're perhaps still more used in the primary care setting compared to triptans for migraine patients. And it's very interesting that there's absolutely no evidence that these work in migraine patients. For barbiturate compounds, there were 10 trials done. Only one was in migraine, which was not placebo-controlled and was not a positive trial. So this practice is not based in evidence at all, and almost always barbiturates result in worsening of the disease. So there's absolutely no role for barbiturates or opioids in the treatment of migraine patients. So that was all about the abortive therapy. Now I'm going to quickly talk about preventive therapy. Now, as I mentioned, 4 headache days a month or 1 per week experiences headaches more than that, then migraine prevention or preventive therapy is considered. If a patient does not have quite that frequency, but the migraine attacks significantly interfere with their daily activities, or abortive medications are ineffective, contraindicated, or the patient experiences significant adverse effects from the abortive medications, and even in those cases, preventive therapy can be considered. So what is the goal of the preventive therapy? And this is very important it's very important to educate the patient. to understand that migraine prevention does not mean that they will never have another headache. It means that the frequency, the intensity of episodes will be reduced. The breakthrough headaches will still occur, may still require treatment with abortive medications. And patients should be encouraged to focus on their overall pattern of improvement rather than isolated headache events. These are the current preventive treatment options that we have. Of course, lifestyle modification helps in reducing triggers. Treating triggers, avoiding triggers helps. Pharmacological treatment involves oral preventives. The main medication classes are anti-epileptics. Topiramate and valproate are the two main anti-epileptics with level A evidence for migraine prevention. And then apart from that, there are two beta blockers which are FDA approved for the preventive treatment of episodic migraine, propranolol, timolol. Amitriptyline is also used for prevention, not FDA approved, but still commonly used. This is pretty decent data for migraine prevention. As you can see, none of these medications were designed for migraine, but found to be useful because they do cause CNS changes. Botulinum toxin A, or Botox, until very recently, this was the only FDA-approved therapy for chronic migraine. Once again, these are patients who have 15 or more headache days per month, as opposed to patients considered to have episodic migraine, where the attack frequency is much less. CGRP monoclonal antibodies are the new upcoming class of medications, which is specifically designed for migraine treatment. CGRP has been shown to be elevated in migraine patients. It's implicated in the initiation of the migraine attacks, and then in the propagation of migraine attacks as well. In the first of this class, Erenumab was approved in May of this year for the prevention of migraine. Since then, two more medications, Tremelimumab and Galcanezumab, have been recently approved, not quite commercially used yet. One of these approvals was just last week. Over the next few weeks and few months, these will be commercially used, will start to get more commonly commercially used as well. And then there are certain non-pharmacological options for the treatment of migraine with double-blinded studies showing benefit, which include transcranial magnetic stimulation, non-invasive vagal nerve stimulation, and then certain devices which perform trigeminal nerve stimulations, and I'll briefly talk about those. So as I mentioned, these are the two big areas of development these days: calcitonin gene-related peptide modulation, and two kinds of medications in the pipeline, or rather three kinds, either CGRP antibodies, receptor antibodies, and receptor antagonists. And then neuromodulation is another area of active research and active development with at least two devices which are FDA approved for the treatment of migraine, and several others in the pipeline. Now, chronic migraines face certain challenges, and chronic migraine patients in West Virginia face certain more challenges than elsewhere in our country. So as I mentioned earlier, until May of this year, botulinum toxin A was the only FDA-approved treatment for prevention. However, West Virginia Medicaid refuses to cover for it, even with a highly restricted pathway. And it's interesting that West Virginia Medicaid used to cover for Botox before it got FDA approval. This is the only Medicaid in the country to deny Botox for chronic migraine, which is not only covered by Medicare, but every major insurer. And Moreover, it's interesting that West Virginia Medicaid covers for Botox for every other FDA-approved non-cosmetic use. And this is a list of those: urinary incontinence, overactive bladder, cervical dystonia, blepharospasm, to include some. Chronic migraine is the only disease that it would not cover Botox for. There's several other challenges that our patients face. Economic burden has been, I mentioned this in the beginning, that the annual direct and indirect costs combined amount to about $36 billion associated with migraine. But interestingly, our population in West Virginia is affected disproportionately by even this. The National Health Interview Survey from 2015 data shows that the migraine prevalence is highest in the population with an annual family income less than $35,000. So this is about 20% of those patients. The prevalence was up to 20%, as opposed to 12 to 13% overall in the general population. Under the age of 65, in Medicaid insured, even higher, with 26%. And over the age of 65, prevalence was highest in the group with Medicare and Medicaid, 16.4%. There's another unique consideration for our population. We looked at 1 month data recently. This was a couple of months ago at our headache center, and the average distance traveled by the patients was about 70 miles one way. About 73% of these patients traveled over 25 miles, more than 50% over 50 miles, and more than a quarter of these patients traveled over 100 miles, with the longest distance being 235 miles one way. Now, it's important to note here, I've been talking about Medicaid and their failure to cover for the FDA-approved treatment options. About 1/3 of our population relies on West Virginia Medicaid for insurance coverage. I'm talking about the WVU Headache Center data. In the country, there are only 484 UCNS certified headache specialists, so accredited headache specialists. There are 3 of us in West Virginia. Fortunately or unfortunately, all 3 are here at WVU, at the WVU Headache Center, and none in the rest of the state. Now, this number, to put this in perspective, so this means that there are roughly 80,000 people with migraine for every UCNS headache medicine certified physician. Now, that's a huge number. And of course, the headache specialists are not the only physicians treating patients with migraines, but even if you double this number, triple this number of physicians who have expertise in treating migraine, the number is still too low. According to the American Academy of Neurology, there were just over 16,000 neurologists in the U.S. in 2013. And again, to put that into perspective, so that means about 2,500 people with migraine per one neurologist. So simply by sheer volume, migraine population is underserved. The WVU Headache Center, this is the only comprehensive headache center in the state, as I mentioned. We are a group of 5 providers, with 3 of us board certified in headache medicine. This is the only headache medicine fellowship training program in the state. So a screenshot of our website. I'll share the links towards the end as well. And all the treatment modalities, the treatment options that I mentioned in the previous few slides, each one of those is offered at the WVU Headache Center. We are also part of several multi-center clinical trials, not just in migraine, but cluster headache, post-traumatic, post-concussive headache disorder, and several other headache disorders. These are just some of the trials that are currently ongoing, which include CGRP monoclonal antibodies, use of CGRP monoclonal antibodies in migraine, in cluster patients, in post-traumatic headache disorder patients, some device trials, and so on. We at the WVU Headache Center offer several types of neuromodulation techniques. They range from occipital nerve stimulation to transcranial magnetic stimulation, frontal nerve stimulation, vagal nerve stimulation, SVG stimulation, and blocks. And what we have been advocating for, and what we have been trying to do, is to be part of, to ensure that we are part of all the major clinical trials that are ongoing, which is one way of helping our patients to have access to the latest and the greatest. And another thing that we try to do is negotiate to be part of those clinical trials. We try that in our patient population, so most of the clinical trials have an open label arm after the double-blind study is done. And what we try to do is convince them that if the disease is not covered by the insurance, then for those patients, they'll extend the open label arm to at least 1 year. And we have had great success in convincing the industry to do that, because what we have in mind, our Medicaid patients, about 1/3 of our patient population, which has very restricted access to some of these treatments. And I'm towards the end, but I'm sorry. It's going to do it again. Okay. So some of the resources that are available for migraine patients. American Migraine Foundation has a wonderful website with a host of resources for patients. I'm sharing this link with everyone. Migrainedisease.com is another organization, and which has a host of resources for the patients. And then American Headache Society is the main physician society of headache specialists, and they also offer a lot of resources for migraine patients. Then there are local resources. WVU Headache Center has a website with patient resources, another website with the ongoing clinical trials. With the integration into the Rockefeller Neuroscience Institute, some of these websites are being updated in transition from being hosted on one server to another server. So some of this information is going to change over the next few months. But I'm pretty sure that these web links will still be functional and be able to connect patients to the desired pages. And this is it for me today. Yeah, I'd be happy to answer any questions at this point.
Thank you, Dr. Najib. Does anyone have any questions before we go to the chat room? All right. I have actually two questions, if you don't mind.
Absolutely.
One relates to the few slides that you had up there about West Virginia statistics. We serve at the Center for Excellence in Disabilities. We obviously serve individuals with disabilities who often have Medicaid, Medicare, and that was a group that you had emphasized that had a higher prevalence. So my question pertains to kind of the additional factors why you think the prevalence for migraines is higher. Is it SES? Is it environmental? Is it something else? And then kind of related to that, does the treatment you give individuals who might have disabilities and might be on other medications differ at all from those who do not have disabilities?
So to answer the first question, it's we don't have good data to exactly figure that out. These some of the data that I shared from the National Health surveys, some of the reasons that they postulated were that in the U.S., for instance, low socioeconomic status is also associated with higher visits for the treatment of headache disorder. And one of the hypotheses was that this not only results in a higher direct treatment cost, but inadequate therapy. Now, there have been separate studies done which have shown that ER visits result in inadequate therapy. So that was one hypothesis. And then another hypothesis is that there are requirements for step therapy. For instance, there are more restricted, step therapy requirements by Medicare, which results in inadequate treatment. And some of the other factors then involve the indirect costs from missing work, not just from missing work, but from not performing while at work in patients who suffer with migraine. So the concept of presenteeism, and so there are several things that are hypothesized, but I'm not aware of any data that has in any studies that have, probably would be very difficult to pinpoint what exactly happens there. Okay. Now, for the other question, treating patients, who have concomitant problems or more comorbidities than others, then of course that's a big challenge. The prevalence studies or epidemiological studies done in migraine patients, especially chronic migraine patients, have shown that the treatment challenges include patients with untreated mood disorders, untreated sleep disorders such as sleep apnea. It not only limits the use of certain medications, but unless those disorders are treated, the outcomes of migraine therapy are also limited. And that becomes a big challenge for the patient to have comprehensive care where all these other comorbidities are addressed as well, in addition to migraine. We try to provide that for the patients, but as I mentioned, if someone's driving from 100 miles away, for them, having 3 visits to see a sleep specialist, to see a behavioral medicine specialist, in addition to a headache specialist, that is more trouble, and that's very difficult.
Okay, so kind of related, stepping off that one, and then I'll be quiet and let anyone else ask you questions. But because we see individuals with various ages and various conditions, if we learn that they are experiencing migraines of any of the types that you've mentioned here, what should we incorporate into our information referral process? Should we ask them to discuss this with their primary care provider? Should we make a referral to you all over at the Rockefeller Center? What would you advise in terms of, now that we're aware of this and that you all are here, right, we have partners, what do we do?
I would suggest to simply refer the patients to the headache center. Okay. Although it's, I can argue that it's just not possible for one center to serve the whole state. But what we are trying to establish is we are trying to identify local primary care providers who are comfortable in treating this disease. But the model that we are looking forward to create is that we do the initial evaluation, and then we give a set of recommendations, a stepwise set of recommendations. And if the primary care provider is comfortable following those steps, in conversation with us, we'll gladly send the patients back to them. they can follow those steps. We'll identify other problems that need to be addressed, other comorbidities that need to be addressed. Some of them might be able to address them closer to home. And from a migraine standpoint, give very detailed recommendations and instructions on what dose to start the medication on, how long to wait before up titrating the dose, what should be the goal dose, how long do they need to stay on the goal dose, what to expect from the medications, and if this doesn't work, what should be the next step, what should be the step after that. And once some of those things have been tried, then they can come back. But if the primary care provider is comfortable in doing that, patients certainly prefer that, and we prefer that because that way we are able to help other patients. So I would say that so far we have been fortunate that we closely work with several primary care providers who are comfortable in following those instructions or recommendations, and I have several success stories to share in that regard. So I would suggest to refer them to us so that we can do the initial evaluation and then plug them in a system.
Great. Thank you.